For optimal access to the thoracic cage, the arm of the patient should be flexed at the elbow, externally rotated, and abducted. The resulting position is in fact the same as you would use to insert a conventional chest tube. This position will increase the distance between the ribs and will thus facilitate scanning of the thorax and subsequent tube thoracostomy or simple drainage. Using anterior and posterior axillary lines as anatomical landmarks, each chest wall can be divided into three main regions or zones. The anterior zone is bounded medially by the sternum, laterally by the anterior axillary line, superiorly by the clavicle, and inferiorly by the lower aspect of the rib cage. This zone can then be subdivided into a superior and inferior region. Note that, to be visualized in the anterior zone, an effusion has to be at least moderate to large, as it usually accumulates first in the dependent aspects of the pleural space with aerated lung tissue on top. The lateral zone is bounded anteriorly by the anterior axillary line, posteriorly by the posterior axillary line, superiorly by the axilla, and inferiorly by the lower aspect of the thoracic cage. The lateral zone can also be further subdivided into a superior and inferior region. This zone is the most common and convenient area to assess for pleural effusions in the supine ICU patient. Small effusion as well as large ones can be imaged in this area. The third zone is the posterior zone, bounded laterally by the posterior axillary line, medially by the vertebral column, superiorly by the upper part of the thorax, and inferiorly by the lower part of the thorax. The posterior zone can be subdivided into superior, medial, and inferior regions. This zone is most often imaged by having the patient turned in a variable degree of lateral decubitus position, as illustrated here. In the ICU setting, this zone is rarely examined. However, with the non-ICU patients, the posterior zone will be the one most frequently assessed when looking for pleural effusions, with the patient in the sitting position. Patients with multiple lines or compromised hemodynamic status will be difficult to position in an upright sitting position. Thus, in these patients, the best area to look for a clinically significant pleural effusion will be in the lateral chest zone with the trunk elevated at an angle of 20 to 30 degrees.